This is a picture of the common sites for palpating your arteries. You have your carotid arteries. And like I said, you palpate one at a time. Do not palpate both at the same time. However, that only applies to the carotid arteries. So when I palpate the brachial arteries, I palpate both at the same time, noting the rhythm, is it regular or irregular, and the force, or, is it bounding, is it thready, is it weak. Then you have your radial and ulna. You also have your femoral, popliteal, posttibial, and dorsus pedatus, or peditus, sorry. So these are the common sites for palpating arteries. These you do need to know. You need to know how to assess them. You are going to assess them when we do your heart failure simulation. You need to practice assessing them on your patients in acute care. You also need to know and note that if you're palpating them at the same time, except for the carotids, that you need to make sure that they feel equal, that you have both in both sides. Let's say that I'm palpating both of the radial arteries, right and left. So I need to make a note. How do I chart it? So I have a scale, a 0 to 3 plus scale. 0 is an absent pulse, 1 plus is a weak, 2 plus is normal, and 3 plus is increased, full, and a bounding pulse. It is possible that a patient has an occlusion in a femoral artery on the right, and they have no pulse, no dorsus pedis pulse, but they have a +4 dorsus pedis pulse in the left, and that's possible. One of the assessment techniques that you will have to do is, if the patient has a cardiac cath, which we'll talk about in a few minutes, you have to assess the pulses in the lower extremities. It's extremely important. So now we're looking at a diagram of the chest and locations with landmarks. It is your responsibility to be very familiar with not only what we're listening to and the area where we're listening to it, but the landmarks. So for example, if I said we are going to listen to Erb's Point, it is located at the third left intercostal. Let me switch this to red. It's located on the third left intercostal space near the sternum. So you do need to know the landmarks because that could pop up in a test question, as far as also knowing what you're assessing. So I use the acronym APE to man, and I think sometimes there's another mnemonic, but I'm not quite sure. This is just the one I'm familiar with. So in other words, what I'm listening to is APE. So the A is aortic. I am listening on the right side of the chest because the way the heart is designed and the way that it perfuses and the sounds radiate, it is best to hear the aortic valve on the right side. Next, the P is the pulmonic valve. The E is your Erb's Point. T is tricuspid, and then the O just disappears. And then the M is your mitral valve. Your mitral valve area is also considered a couple of other things. Your point of maximum impulse and the apex of the heart. The base of the heart is also considered where you listen to the aortic valve, and it is the top of the heart. So these are things that you do need to know how to assess, and we will practice assessing them, whether you guys practice on each other or you practice on one of the mannequins. It's something that we are going to do in class, so you do need to be familiar with this. Okay, next we're going to look at the chest. So part of the assessment for cardiac is that you actually are inspecting the chest and also palpating. So you can have something called thrills and heaves. And when I talk about palpating and inspecting the chest, you're actually looking over the heart or the pericardium, and you're looking for you're actually looking for pulsations. If you have a super thin person, it is possible that you can see those pulsations, but typically, in general, you don't. When I talk about a person who has a heave, if you put the your fingertips on the patient's chest or over the pericardium, and you have a lift off the chest wall, this can be seen or it can be palpated, and it usually is typically caused by something called left ventricular hypertrophy. So normally there should be no pulsation seen or felt. The patient is when we auscultate, we're auscultating and listening for S1 and S2. S1 is the first heart sound that you hear. It is associated with the closure of the tricuspid and mitral valves, and that is the lub. The second heart sound you hear, which is S2, is the closure of the aortic and the pulmonic valves, and that is the dub. So you have the lub-dub sound when you are auscultating for the heart rate. Anytime you're auscultating a heart, you can use the diaphragm. If you suspect that a patient has a murmur, then you would want to use the bell of the stethoscope because it's a more amplified sound that allows you to hear more clearly. So when we also talk about listening to heart sounds, you can have extra heart sounds, which is an S3 or an S4. It is best heard, like I said, with the bell of the stethoscope because they're very low pitched. Something you can do is have the patient actually lean forward while they're setting. This enhances the sound. And the other thing you can do is have the patient lay on their left side, which will also enhance the sound. If they lay on their left side, this enhances the sound in the mitral area. If they are setting forward, this enhances the sound over the aortic and pulmonic area. The other thing you want to do is when you are auscultating the apical pulse, you also want to palpate the radial. You want to see if they are simultaneously together in rhythm, whether it's regular or irregular, while you're listening and feeling. If you do have an apical pulse and they're not equivalent in their count, you need a second person to come in, and one person would actually auscultate the apical pulse and the other would count a radial pulse for 1 full minute, and you would note the difference between the two numbers. This is called a pulse deficit. If that occurs, it's possible that the patient has a cardiac dysrhythmia. S3, so if you do hear an S3, and when we talk about S3 and S4, they're considered murmurs. Right now, don't get too excited about being able to distinguish murmurs. If you know if a rate is regular versus irregular, that's wonderful. The ability to distinguish what murmur is what is an advanced skill and will come with time, and it also may just depend on what area you end up working in. But you should be able to distinguish if there is a regular rhythm versus an irregular rhythm.